About 80% of what we spend on healthcare in this country goes to treating chronic disease. Most of it is preventable, and that gap between what we know works and what we actually fund is what we're going to talk about today on the policy stack. Make America Healthy Again has put prevention and chronic disease higher on the federal agenda than they've been in a long time. And at the same time, the CDC is facing a 53% budget cut. Medicaid was cut by over $1 trillion. And the agencies that run the federal public health system are being reorganized or eliminated. Dr. Anand Parekh has spent a decade at HHS building prevention programs under Bush and Obama, another decade at the Bipartisan Policy Center, and just became the inaugural Chief Health Policy Officer at the University of Michigan School of Public Health. He also wrote a book on this, literally called Prevention First. Today, we're going to talk about what's actually being cut, what it costs, and what durable prevention policy looks like from here. Welcome, Anand. Welcome, Dr. Parekh.
Thank you, Lisa. Good to be on with you.
Yeah, wonderful. So just like we said in the opening here, we are in a moment of contrasts, right? We're talking about making America healthy again while we are cutting and reorganizing some of the fundamental building blocks of, federal health policy and prevention and public health. So just to start out, let's talk about how you got here. Talked a little bit about your background, but what brings you to this moment in time and joining the University of Michigan and talking about prevention and public health?
Yeah, so my journey started with political science, went to public health, went to medicine, then public service, and then public policy. So it's come full circle over the last 30 years. And, what was really getting me up in the morning was this idea of how do you make a change on a broader level? How do you help not just one individual at a time, but hundreds, thousands, and millions? And, after the last 20 years, I've come to the conclusion that in fact prevention needs to be our nation's top health policy priority.
Yeah, I mean, a doctor practicing needs to treat the person in front of him or her, right? Needs to treat that person in front of them, and you can't really think about population health, about the many, when you're looking at a patient directly in the eyes, right?
That's exactly right. I spent the first several years of my career seeing patients not just with one chronic disease like heart disease or diabetes or COPD, but with multiple chronic conditions. And much of healthcare is managing individuals with multiple preventable chronic conditions. Extremely, extremely important. But you don't often have time to take a step back and really ask yourself, well, could we actually have prevented those many conditions in the first place? And that's why sort of a focus on prevention, I think, is so important. And there are really two ways you can do prevention. One is within the four walls of the clinical or healthcare setting, and you do that through primary care. And then you do it outside the four walls of the clinical or healthcare setting, and that's really what public health does. And so by focusing on public health as well as primary care, I've come to the conclusion those are the best ways where we can advance a prevention first.
Yeah, definitely. So let's talk a little bit more about what is this federal sort of prevention system as well as states, right? What is the prevention infrastructure and the public health infrastructure, because they're a little bit different. Like, what does that look like previously and then maybe today?
Yeah, so, at the federal level, particularly the U.S. Department of Health and Human Services, the annual budget is about $2 trillion. And about 90 to 95% of that, Lisa, really goes to what we call mandatory spending. And we're an insurance company, we're paying bills, or we're paying for some direct services or providing assistance. Really only about 5% of that, or about $100 billion, goes to what are called discretionary agencies. So all the three-letter acronyms that we know of, CDC and FDA and NIH, all of their budgets together, are about $100 billion. And of course, not all of that activity focuses on public health or prevention. So public health and prevention get a small share of even that discretionary budget. And over time, many of the budgets of agencies such as CDC they had really been flatlined, if you will. And in the last couple of years, they've been significantly decreased. And so we're seeing a reduction in funding in the very agencies that really concentrate on prevention and public health. Again, the CDC provides a core amount of the funding to states and localities for public health activities. HRSA provides significant resources to federally qualified health centers, which are the engines of primary care in so many communities across the country. Agencies like SAMHSA provide a core amount of the prevention resources and grants to states and localities. So all of these agencies matter. Now, at the state and local level, they are reliant on the federal level. Certainly, there are state dollars that support state and local activities. Sometimes there are local dollars as well. But really, this is an infrastructure where the federal role is critical. And when you don't prioritize it at the federal level, then it trickles down those implications at the state and local level. And
yeah, definitely. No, I mean, I think you just look at the infrastructure side, right? You know, I guess we're lucky that the Nebraska quarantine unit is still functioning, because that's where the bulk of the people who were on the cruise ship with the hantavirus outbreak from the US have been moved to. Luckily, that place is still, you know, operating, and the people running it have, you know, incredible protocols and are incredible, you know, public health and medical professionals. But that's infrastructure that you sure want to have in place when there's an outbreak, when there's some kind of, you know, situation of public health concern, and those things have to be funded. They don't just magically fall out of the sky. It's just really something. Let's talk about something a lot of people may not know, which is the United States Preventive Services Task Force, and what it means towards what types of preventive healthcare actually gets funded. Can you talk about what this is, why it matters to, you know, primary care, to screening? Like, say more about. I think people don't necessarily understand the role of this task force and what's actually covered in preventive healthcare.
yeah, so the U.S. Preventive Service Task Force is an independent body of experts that look at various services that can be provided in the healthcare setting to detect really early detection, various chronic diseases as well as illnesses. So we think of them as our cancer screenings. We think of them as our immunizations. We think about them as our sort of screening for substance use as well as counseling. All of these things are clinical preventive services. And for many years, these experts would, on a regular basis, and they still do this, look at various preventive services, and then they would grade them, whether these are services where the benefits outweigh the harms, and whether the standard of care ought to be that individuals should receive these services. When the ACA passed in 2010, there was an additional provision that said that from now on, the recommendations that are made by this task force would also trigger private insurers, and then also Medicare, and then to a certain extent Medicaid, those insurers to cover these services for their members without any cost sharing, which is important, which is exactly what we want. We want high value evidence-based services to be accessible to the public without barriers like costs. And there was significant literature to suggest that cost was a barrier. So what this ACA provision did was take away that cost barrier. And over the first several years, we did see an increase in uptake for particular cancer screenings. For example, we did see reductions in disparities between individuals who had lower income. Racial and ethnic disparities as well were reduced. So it's a really important policy piece. Fast forward a couple of years, with all of the lawsuits against the ACA, there was a lawsuit and several against that provision in the ACA, where a number of employers said that actually this is sort of coercing us to cover these services without cost sharing. And they were particularly focused on several services that they philosophically or from a religious perspective just didn't agree with. Think about contraception, think about sort of HIV services that in their minds they did not feel like they wanted to provide for their employees without any cost sharing. This case went all the way up to the Supreme Court, and the Supreme Court actually upheld this idea that insurers and employers need to cover these preventive services without cost sharing, essentially. And so that is still the law of the land. I think there is a little bit of concern right now because this task force has not met in about 18 months since the Trump administration has started. Recently, we've heard that they are going to restart meetings this summer, the summer of 2026. But there is a bit of a concern in terms of who will be on this task force. So it is thought that all of the current members might be relieved of their duties. There's a call out for new members. What might they focus on? Will they go backwards in terms of revisiting recommendations they've previously made? What will be on their agenda? So I think there are concerns there, but it's really important because these are preventive services that save lives, and they're the ones that all of us have had, right? Whether it's immunizations or cancer screenings or cardiovascular screenings or screening and counseling for substance use disorder. These are really, really important services that the American public, when they need, ought to be able to access.
Yeah, and this was the Braidwood litigation and the case that you were referencing where the coverage of those services was challenged. It's just interesting because obviously if you looked into the details of how these screenings and services are assessed, it's an extremely high bar, right? It is really looking for very, very high quality evidence to benefit that will result in, better health for populations. But, certainly frustrating to see some of those things challenged that really will help people stay healthy. I've had questions about some of their choices before. I think that there's I think from my perspective, at least, I think there's really high quality evidence around some enhanced screenings around mammograms for women with dense breasts, for example. That's been a challenge and a question now for many years on the USPSTF. But they have a very high bar for evidence of what they will ask, insurers and others to cover with no cost. And it's a really important part of the coverage and the prevention of chronic illness in the country.
Yeah, and I will add one more point, Lisa, that unfortunately the uptake rates of some of the highest value or those services that have the greatest evidence base, the uptake rates are really suboptimal. So we do pretty well when it comes to cardiovascular screening, cancer screening, sort of 60, 70%. We think about, breast, colorectal, others, but things like substance abuse, mental health, evidence-based screenings there, we do quite poorly, only about 30 to 40%. So that's where the focus needs to be, I think, right now. How do you increase uptake? So these services are out there. We've made them free, essentially, but still we're getting suboptimal uptake. So what are the other barriers there? And how can we help people ensure that they're up to date with their screening?
Yeah, exactly right. So that's sort of the coverage piece and looking at, prevention of chronic illness at a population level. Those are some of the tools that are available to us. At the same time, you mentioned earlier the trust issue, right? And I think, some of those trust issues made people mistrust vaccines, for example, even the measles vaccine, which is incredibly effective and safe and, been around for quite a long time. We gave up a measles elimination status as a country, potentially due to or, affected by this loss of trust issue in public health. What are you looking at both in your new role at the University of Michigan and broadly about addressing this trust issue, this loss of trust at the population level, the county, the state, the country level?
Yeah, one of the things that we're about to embark on is to really get out of our ivory tower here at Ann Arbor, Michigan, at the university, and really get out there through a series of public health town halls, and it's essentially this idea of going out there and just listening to people about, well, what are the issues that matter to them. It's interesting in public health, and the first assistant secretary for health that I worked for Dr. John Akwanobi over 20 years ago used to tell me this, and this idea that public health is made up of two words, right? We spend a heck of a lot of time on that second word, health, and try to understand all the science, the evidence, and all. You don't nearly spend as much time on that first word, public, the very population whose hopes, dreams, and aspirations that we ought to know, because that's who's we're trying to serve. And I think we need to spend a little bit more time listening to people, meeting them where they are, helping, first listening to see what they know about particular health issues that they care about. And one of the things that we're going to do then, partnering with local health departments, is bring some experts on those issues that people care about, and have a dialogue, so we can provide, if it is some science, and we can provide, that's great. If there is some learnings from elsewhere that we can provide, that's great. But really to have a dialogue with empathy, without judgment, building bridges with communities that oftentimes we spoke to from a distance, without really understanding where they are and what their, again, hopes, dreams, and aspirations are. And so, it's just one small way of really getting out there and talking to people. And it's hard, right? We live in this era of social media right now, where we're in information overload, and AI is just going to multiply that many, many fold. And people are getting their information from so many different places. But I think there's something to be said about face-to-face meeting people and showing that you care. And they may not, their worldview may be different. How they look at a particular issue may be different. But that's all the more reason to engage.
Yeah, I think the public health communication issue generally is massive. I think this very moment in time we're sitting in right now is just a great little vignette of how that goes wrong and can also go right? This hantavirus outbreak and the very dramatic media coverage, but also the lack of sort of authoritative voices. There was both not enough media coverage and too much dramatic media coverage, right? There was nothing, right? The New York Times, the big newspapers were barely covering the story, and people on social media were melting down with sort of PTSD-esque reactions from the COVID pandemic. And, we're going to be locked down again. And it's like, well, actually, no, but also then you have sort of the tabloids writing these very dramatic, like, this person has escaped and this person is on a plane, and so you just had this total just little pretty short, luckily fingers crossed, vignette of how it can go wrong again. What have you seen? What do you recommend that public health professionals do when there is a sudden and dramatic need for reliable and factual information that also doesn't pander to or talk down to people who are rightfully afraid and quite frankly do have PTSD as symptoms from living through the COVID pandemic in this country?
I think it's important for public health professionals to be able to say what we know, to say what we don't know, and to also remind people that as soon as we learn more, that we will promptly inform them, and that it's okay to say that, hey, we don't know, because oftentimes during these kinds of crises, we're all learning in real time, right? And so communicating to the public that hey, we're all in this together, and we're all learning in real time, and as we learn, what we previously said may or may not be exactly the same, and sort of prefacing that. So in case that things do change, people don't say, oh, well, they're changing their mind again, right? And so I think that's really, really important, being sensitive to people out there who are having sort of the COVID flashbacks. I think it's really important also that we're humble, and perhaps sometimes less definitive than it's one thing to reassure the public, which is great, but maybe we ought to focus less on telling people how to feel and just providing information. Being, again, as I said, a little bit more humble and a little less definitive, I think can be helpful as well. So again, there are all types of people coming at this from sort of different vantage points. So it's hard to speak to everybody at the same time. But if the principles overall are telling people what you know, telling people what you don't know, making sure that you're in constant communication, as well as sort of being humble, I think, you know, I think that's probably the best approach.
Yeah, definitely. I think anchoring too much on, one moment in time is difficult. People really, they do want to hear that things are going to be okay. And that's not something that you can say if you're basing your information on science, right? If you're basing your information on, disease progression or things that are just unknown, right? Like we don't know. We didn't know until a few days ago that the Andes strain of the virus, was what was discovered, and there were no obvious mutations. Same thing we're looking at, an attack rate that we know, all this information. So it's really hard to give people what they want to hear. But like you said, I think just being very clear about what is known, what isn't known, and how to get more verifiable information is really important in these situations. And local, right, as well. Like it's important that somebody, in your state is hearing from, your health officer in your state and information that is relevant to them. I don't know that we're going to be at a place again where there can be like a big CDC spokesperson who is universally trusted by the country, right?
Yeah, and I think, I hope that's not the case. I hope that, I wish there was a CDC director right now. I wish on Anand Parekh, even though we know it's not going to turn out, lead to the next pandemic. I wish there was a press conference coming out of Atlanta right now where the CDC director would just, take the time and go through exactly what we know, what we don't know, when we'll know more. But then also not just hear from the CDC director, but hear directly from the subject matter experts and the career civil servants, and many of whom are the world's experts in hantavirus, and they answer questions that are commonly being asked, not only in the media but by the public, and so I hope that happens. It hasn't happened yet, but I think these are the types of things, transparency, that build trust with the American public.
So we're covering a lot of ground between prevention and public health. Let's go back to prevention and let's talk about your book. Tell us about what you wrote, why, what we should know about it. What was your impetus in writing this book on prevention?
Yeah, so it was really sort of a summary of my learnings over the last 20 years, both at Health and Human Services as well as the Bipartisan Policy Center, all with the overarching message that prevention needs to be our nation's top health policy priority. Now, it's something that, at face value, everybody ought to agree. Like, okay, well, that's obvious. Of course, prevention should be, but in my experience, what I've learned, Lisa, is that it's been difficult to prioritize prevention, even though everybody agrees with it, as the top priority for a number of reasons. One is when it comes to policymakers, in DC itself, they are pretty reactive, right? There's always the crisis of the day and you're reacting to it. Prevention demands people being proactive, right? You're trying to prevent something. The other thing about prevention is it often takes time, right? And it takes patience. And that's difficult for policymakers and lawmakers in DC. They want quick wins. They want something splashy. And then oftentimes when prevention is working, you've averted something bad didn't happen. And that's hard to show, right? A lot of the wins are oftentimes invisible, making it difficult. Oftentimes, lawmakers don't understand the underlying science behind prevention. And if they don't know whether it works, sometimes they'll just say, well, isn't that the nanny state? Or, you're trying to tell people what to do. And so you can get into sort of those types of conversations. The only reason why prevention hasn't been prioritized, back to our point, we don't spend a lot of resources on prevention. And in our healthcare system sector, prevention is a pretty small sliver, which I'll get back to in a moment. And finally, there's really no grassroots movement for prevention. I mean, you go to DC and there's an organization for every single disease or condition that you could think of, but nobody's sort of going around saying, all right, we're sort of part of prevention. So lots of reasons why what you would think everybody would be obvious. Prevention just hasn't become, the top priority. So in my book, I talk about the various opportunities to elevate prevention, both within the formal clinical setting and outside the formal clinical setting. And I come up with a number of recommendations for federal policymaking to elevate prevention.
Yeah, I mean, I think one of the core problems around prevention is, right, who is paying for healthcare and the time frame in which they expect to see the benefits accrue from that healthcare that they paid for, right? And so prevention might be some of those screenings, for example, and then the person changes their health insurer coverage, or they go in and out of Medicaid coverage, and many years later they do or do not sort of get cancer in some way or whatever. The cancer is found early or it's found later, right? And it's the cost therein, or the counterfactual, accrues much later in the person's life and that coverage. And so it's really tough when you're breaking up the who pays for the health of populations over so many different payers over so much different time.
That's exactly right. There's so much churn, as you know, in the insurance industry, and even employers. I mean, the average American changes jobs every 20 months or so, and so this only works if all insurers and payers and employers are in this together. Because you might lose people, you might lose that prevention investment, but you're gaining people as well,
Right.
who hopefully have benefited from prevention. So this really works best when everyone is in this together, and all payers of healthcare invest in prevention. But that's certainly an issue. And I think the other thing about prevention is sometimes there's sort of a double standard. Oh, well, if it's not saving money, it's not important. Well, we don't say
What's
that.
the out? What are we trying to do here? We're trying to create better health, right?
That's right. That always has to be sort of the top
Right.
reason we focus on prevention, to improve health and to save lives. Now, that's not to say that there aren't a lot of preventive services that are cost effective. Some that are actually cost saving, but the majority are probably not going to save money, but they're going to improve health, right? And that has to be sort of the most important focus.
Yeah, yesterday I was talking to Dr. Sudeep Bansal, who's a primary care doc and ACO guy as well, and we were talking about sort of the long-term effects of this accountable care, value-based care movement. And his take on it is just, there's nothing that gets us away from looking at the social determinants of health and the drivers of health that are related to social outcomes. We were talking about, things like hyperlipidemia, and somebody like me who has tremendous access to care. And, what is the number to treat for someone like me versus someone who doesn't have access to care and can't afford, the best primary care available or whatever else it is. And I guess I'd be interested in your thoughts on, can you in any way, shape, or form separate the prevention conversation from the social determinants of health or the social drivers of health?
Yeah. So I think on the social determinant side and the social driver side, there's really good data now looking at the U.S. compared to other countries, and then states within the United States compared to other states. And if you look at the ratio of social services to healthcare spending, and on the social service side, we're talking about economics and education and food and housing. If you look at how much other countries spend on social services versus healthcare, it's about 2-to-1, that ratio. But in the U.S., it's 1-to-1, because we spend so much on healthcare. And many of those other countries, particularly OECD countries, have better health outcomes, higher life expectancy, et cetera. Even then, when you look at U.S. states, and you look at the ratio between social services and healthcare services spending, those that have a higher social services and healthcare services ratio, they have better outcomes at the individual and population health level. So you'll see states like Hawaii, and you'll see states like Washington, and states like Utah that have better health outcomes, and they're spending more on social services relative to healthcare. And on the flip side, you look at that same graph and you see states like Mississippi, and you see states like Arkansas, who are spending a tremendous amount on the healthcare side and less relatively on the social service. So this matters. I mean, how we spend our resources really matter. And so, I think, so we have a pie. on the health side, and then there's a pie outside the health side. And I think you can make an argument outside of health. We probably need some greater investments on the social service side to improve health in our country. And then on the health side of the pie, which is $5 trillion, which is roughly what we spend on health in this country, less than 3% goes to public health. Only about 5% goes to clinical preventive services, primary sector, and only about 6 to 7% goes to primary care. And those three categories are not mutually exclusive.
Mm-hmm.
And so at the end of the day, Lisa, I think the question is where you spend your resources, define your priorities, and your priorities define your values. And the question for us is not how do we become a healthier nation? It's do we have the will to become a healthier nation? Because we know what we need to do. We need to invest in prevention, primary care, and public health. We need to invest in those social services. And if we do that, then we're just going to have a healthier nation.
Yeah, that's exactly right. And I think there's, legitimate concern about spending Medicaid dollars on social services, and yet we have to spend some money on social services. And I don't fault, states for trying to figure out creative solutions to this dramatic gap that exists that definitely affects health outcomes. It's very challenging. So one of the conceits of this podcast is that we talk about the policy stack. So the stack of, overlapping statutes, regulations, funding, infrastructure, et cetera. And so, this is what I've got. And I'd love your edits or comments, right? There's the federal statute. There's, parts of the Social Security Act, Medicaid, Medicare, the Public Health Service Act. There's the ACA we talked about, the Preventive Services. There's the CMMI authority to test things like, accountable health communities or any of the primary care models. So there's the federal side. Then there's the appropriations and budget, right, where these agencies are funded or not, where CDC is funded or not. I think that's always a question whether, something like SAMHSA or programs are eliminated. There's generally the organization around HHS. They're talking about merging some of those agencies and what that would do. There's like Medicaid and specifically the federal state matching structure, FMAP, where, Medicaid pays and supports the Medicaid program and CHIP program in each state. There's the ACA marketplace coverage, the subsidies, which, as we know, are gone in most cases, or many of the extra subsidies are gone. There's the preventive services coverage we talked about with the Braidwood ruling. There's the annual wellness visit stuff. There's the public health infrastructure. That's you were talking about the funding that is not already fixed, not already required. So when they put out grants to different states or organizations, there's everything we talked about on the social determinants side, including, programs like SNAP and WIC and things that provide some of that social services support. And then there's sort of all of the primary care pieces. What did we miss? What else is in the policy stack for public health and preventive care?
I think you've been incredibly comprehensive there, covering so much. I think what was really telling as you outlined all of those elements is how many of those elements, unfortunately, are currently under threat, if you will, or are in the midst of receiving less attention, less focus, or less resources, right? And that is going to be the near-term challenge for us. How do we continue building a healthier nation when the building blocks for prevention, primary care, and public health are being cut? Now that's not to say that the current HHS secretary's focus on reversing the chronic disease epidemic and make America healthy again, that there aren't elements there that are important. It's just that, unfortunately, many of the drivers of chronic disease and poor health and healthcare costs, you think about tobacco, you think about physical activity, you think about alcohol, you think about preventing opioids, substance use disorders, and mental, so many of those things are either not being focused or talked about. And even the one area where I think the secretary was rightfully focused on poor diet, which is one of the leading risk factors for mortality in the United States, the track record thus far has been pretty mixed, right? So on the plus side, we're trying to take out additives that are added to ultra processed food. We're trying to get healthier options for the SNAP program. Great. We're trying to get synthetic dyes out of food. Well, okay, it sounds good. How much of a health benefit are we going to get? Probably not a lot. Are we going to reverse the chronic disease epidemic? Probably not that way. But then there's so many things that we're not doing. Are we really changing the commodity subsidies in the Farm Bill to focus on fruits and vegetables? Are we getting supermarkets and grocery stores into food deserts through healthy food financing initiatives? Are we tackling ways to reduce sugar as well as added sugar as well as sodium? Are we putting front of package labels on there so consumers are empowered? So there's so many things that even in the poor diet space that we could be doing that we're not doing. And if we truly want to reverse the chronic disease epidemic, which I absolutely agree is a number one issue, we got to start focusing on those things as opposed to what we hear about in the media, which is the administration's focus on vaccines and peptides and fluoride and electromagnetic radiation and raw milk and all of these issues that are not going to reverse the chronic disease epidemic. We know how to do that. Let's focus on those issues that we know will lead to tangible progress.
Yeah, that's great. And so where can folks learn more about you and your work and get your book? Say more about how we can keep up with what you're doing at the University of Michigan and beyond.
Yeah. Well, I'm currently enrolled at the University of Michigan School of Public Health as Chief Health Policy Officer. And what I try to do here is to translate the care, practice, and research happening at the school and the university to policymakers to drive positive health impact. And so I'm oftentimes, my audience are policymakers at the federal and state level, the public, innovative partners. And so much of what I'm doing is based on what I did in Washington, D.C. over the last 20 years in government and then just outside of government, working with Congress. I'm still very much focused on issues related to prevention, primary care, and public health. My book, Prevention First, Policymaking for a Healthier America, the second edition, came out, about 18 months ago. And, so that book is out there for individuals interested in these types of topics. But, I'm going to continue to be engaged in policy and to do research and to speak out on these issues. I think we need more voices focused on these issues. And, I'm always optimistic and I'm always hopeful. Right now, it seems like there's quite a bit of mitigation to be done, but I'm hopeful there'll be more opportunities in the coming months and years to continue the important focus on prevention, primary care, public.
Wonderful. Thank you so much, Dr. Anand Parekh.
Thanks so much for having me.